Afternoon, everyone. Welcome to our VCSQI fall meeting. It feels like more of a summer day out there, but we appreciate you making the trek through the heat here, coming out to our monthly or quarterly quality committee meeting. I'll provide a couple introductory comments. I'm Eddie Fauner, VCSQI Executive Director. For our quality committee session this afternoon, we have a little bit different format than we've had in the past. The background is that a couple months ago when we were doing our planning for the meeting, I was speaking with Dr. Speir, and I asked him, Dr. Speir, what do you think would be a good topic for our quality committee session? I really want to make it a robust 2-hour period here. And he said, well, ask the quality committee members, see what's important to them. And hopefully you can hear me. It sounds like the mic is cutting out a little bit. But I asked the quality committee members, and they said, well, let's have a panel discussion with Dr. Speir and Dr. Shor. We'll have a leading cardiologist and a leading heart surgeon. And how often do you get two guys with that much, intellectual power and clout in a room together at the same time, and where you can have a conversation with them? And he kind of looked at me, furrowed his brow, and said, have I just been voluntold here? And so we appreciate our two illustrious guest speakers here, Dr. Bob Shor and Dr. Alan Speir from Northern Virginia, and they're going to be our heart team expert panel. We've solicited some questions from you all, so we're going to run through those. Sherry White, our VCSQI Quality Improvement Advisor, will run through some of the questions. We are going to basically go through the probably 5 or 6 questions that people have submitted first, and we'll do a vote based on a show of hands. The scientific voting mechanism here will basically just be to decide what questions are most important and to prioritize the topics here for our two guests. And with that, we'll get right to it here. And Mike will present at around 4 p.m. I think on some data review processes, and we also have some other discussion slides and FAQs available as well. I think Mike was also voluntold, so thanks Mike for stepping up again. But I'll hand it over to Sherry, and we can run through our discussion questions. Thanks all for being here today. Sherry?
Housekeeping. There's restrooms along the wall here. Wi-Fi code is listed here, and there's also sticky notes on your table to let you know which network and the password. And if you need anything, let us know. So let's go through the questions. And actually, gentlemen, if you want to take a seat, please feel free. You know that we want to make sure the guys with clout are comfortable. Okay, so the first set of questions relates to coordination of care. So the first question we had, or a statement, or one of the topics of discussion, care coordination consultations regarding plan of care throughput and clinical decision trees. Can you show me a raise of hands who would like our two guest speakers to talk about this topic as it relates to priority? So the most was going to be first. So if you're interested, raise your hand. Okay, 1, 2, 3, 4. You got that for me? No, Peter? Thank you. The next question we have, is there a research project that we can work on together and combine our data? For example, MI patients going to surgery and how to avoid post-op AKI or stroke. What is, show of hands, anyone interested in that? 1, 2, 3. 4, 5, 6. Okay. Our next question. Someone was particularly interested in how other hospitals are making information seamless between cardiology and cardiovascular surgery when shared patients follow up with other offices or go back to the cardiac cath to another hospital that does not have Epic or a review system, a record review. Show of hands, interested? 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay. The next question refers to readmission. How do you set up post-op procedure care to prevent readmissions? Who's interested in that topic? 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay? Okay, the rest of the questions are VCSQI specific. We are concerned about losing participation because of program issues related to combined meetings. Do we need to have some meetings separate? Who's interested in this topic? So this relates to the cardiology and surgery combined meetings. 1, 2, 3, 3. Okay, quality and database for cardiology and surgery are very different. So how do you pick what is important for both groups? Who's interested? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, so it seems like this might be the first question. Yeah. Okay, so gentlemen, would you please answer the question for our group relating to quality and database for cardiology and surgery, which are very different? How do you pick what is important for the group?
Okay, thank you. Let me start off by saying who I am, because there's a lot of new faces here, and I think a lot of the questions reflect, despite having worked on a lot of these topics over the years, for those that are new, and we're going to spend some time talking about that, how data transfer can occur. First of all, I'm Alan Speir. We put this organization together in 1992. I've been chair of it for a lot of years. And I'm a practicing cardiac surgeon. I'm the head of the cardiac surgery program for the Inova Health System, and I'm the co-director of the Inova Heart and Vascular Institute in Northern Virginia. I don't have, as reflective of these questions, I don't have the definitive answer for a lot of these, because so many of the things we've done since the inception of the group has been a collective and collaborative effort where we jointly have come up with directions and agendas and importance of what we're about. The real issue regarding these issues, the real issue regarding this question to me is, first of all, there's a practical issue. We have to fill out the NCDR information and the STS information. So they are embedded in those databases, plus the other 9 or 10 databases for which many of us are involved with, the data elements. They're in the process of being challenged. As you know, the American Association for Thoracic Surgery is questioning the volume of 400 plus data elements in the STS. They want to make it an STS light. There's a lot of conflict about this. I don't know where that will go, but we're part of those discussions. But the point being is that we've got information that we're already doing. Secondly, we're still in the relatively nascent phase of having cardiology and cardiac surgery together for both the clinical data as well as the cost data. We have inpatient, we have that done, but we'll talk later about a pretty invigorating conversation we just had during the past several hours about getting the ambulatory cost data. So the strength of this group has been quality and cost, improvement of outcomes, lowering cost. So what has been, I think, our benchmark, particularly in surgery, has been to look at the evidence-based guidelines that are out there that we can then sort of establish as part of us in how we can integrate some or all of those guidelines within our different institutions and see, based upon that uniformity, what the outcomes are and can we save costs by doing that. So because there's much smaller numbers of surgeons, there's much more finite or fixed information through the STS, that was much easier. So I really think that the challenge is going to be for the cardiologist to operationalize that direction, because in looking at appropriateness criteria for a PCI, looking at the cost associated for inpatient and outpatient. These are challenges that we're all going to have to collectively talk about. But to me, the biggest change in this will be the length of follow-up, because the 30, 60, 90 days isn't going to get it. What will separate us will be to follow these patients for a year. And then how can we do that? I have some ideas we can talk about, but and how we can track that. Because we know that so many patients that have PCI then get bypassed and then get follow-up outpatient other interventions. So you all may not even know those things, but the group that we're talking to does know those things and can give us that information over the longitudinal time. So we're trying to find ways that we're not fixed to the human data that has to be a human inputting that data. Rather, what are other sources of information we can get that we can learn from that can tie back to what we started with? So this isn't expected to be added burden on you all. Rather, there's other information we can go out and get that's already being collected. So to go back to the question, yes, they're different, but they're not, because they are the same patients oftentimes. We pick what's important to both groups because they're going to be, the pendulum's going to swing back for a period of time, I would think, to cardiology, because I'll say behind, just to poke Bob, but because they need to get motivated to start looking and be more, but they came in this late. So their application of evidence-based, their documentation of that, it's not behind, it's just they've gone a different direction for a while. So with that in mind.
Thank you very much. For those that don't know, I'm Bob Shor. I'm also in Northern Virginia, so we have the pleasure of working together for more than 30 years. And I'm part of Virginia Heart, which is an independent but affiliated large single specialty practice in Northern Virginia with Inova. I came to VCSQI as a past, when I was governor and president of the Virginia chapter of the ACC, and have had a great interest in bending the quality cost curve, and took this interest when I was chair of the Board of Governors nationally and on the Board of Trustees of the American College of Cardiology. So I'm really, really glad we're moving along. It's been a slow gestational period. I thank everybody for their patience as we move forward with the cardiology piece. We are really starting to gain momentum and progress. I feel like we're a ball rolling down the hill that's gathering steam. So with that, I did want to say there's always the desire to have fewer elements in a database so you don't have to sit there and enter. NCDR actually in some ways is going the other way, and that is asking for additional elements, and that's because of the issue of risk adjusting. A complication in a post-arrest patient mortality is different than an elective case, and there are obviously gradations in between, and so there's a lot of additional information because ultimately we want to be able to take care of the patients, but the outcomes have to be reflective of how sick they are. So NCDR is actually asked for some additional information. I think from my perspective, addressing one of the comments that Alan made, the American College of Cardiology has had robust appropriate use criteria for probably close to 20 years. And they've been updated. We have multimodality appropriate use, trying to take, again, quality and cost and appropriateness into the decision-making process. To answer the specific question about how do you pick between both groups, one of the beauties of what we're doing, because there's such crossover between patients that end up having surgery and patients that have PCI, they go both ways, is that we are now going to be looking at longitudinally, as Alan said, these patients, and we can then focus in on the patients that cross over. The ones that have surgery then end up getting PCI, and the ones that have PCI then end up going to surgery, and then defining what are the characteristics that seem to identify one patient group or another. And we're going to need your help in doing that as well. All hands on deck, and more eyes looking at it will be very helpful to us. And I think that was to allow time for other questions. I think that's anything else for either of us regarding this specific question? Next question.
Whether they share the shared information or the readmission, they both had 9 votes.
How do you set up the post-procedural care to prevent readmissions?
Yeah, Dr. Speir wants to do readmissions, so let's do readmissions.
Okay, so I'll give you the cardiology perspective first, and then since Alan spoke first on the first question. The two main issues from a cardiology perspective that with bundled payments and readmissions is heart failure and post-MI. Less so post-PCI, although the PCI may be associated with an acute coronary syndrome or an MI. What we have done, and we look at, again, knowing the risk-adjusted event rates is very, very important. So entering the accurate information in these registries is incredibly important. And we look at the observed over the expected. But what we have done is we have pre-identified patients early in their hospitalization. Are they an MI patient who's going to need early follow-up? Are they a heart failure patient that's going to need early follow-up? We have heavy use of advanced practice providers in the hospital to help us coordinate the follow-up so that they're seen within roughly 5 days, 5 to 7, depending upon. So the transition of care becomes critically important, and someone has to take ownership of that. To be honest, if you leave it to the doctor, it's not going to get done. And so as you're setting up these programs, having an advanced practice provider it becomes critically important in the transition of care in these patients. We are try to be rigid in the application of guideline-based medical therapy because it makes a difference. So not only are we careful about how soon the patients are in the office for follow-up, we make sure they're taking their medicines and that they're the appropriate medicines. And if they're not on guideline-directed therapy, you document why they are, what's the exclusion. For these patients also, cardiac rehab plays a huge role. And so we have worked closely with the cardiac rehab programs. I happen to be medical director of cardiac rehab at Fairfax, Inova Fairfax. But in the Inova system, we've taken a system-wide approach in trying to push the easy button at discharge for these folks to get entry into cardiac rehab. And we are making progress. Unfortunately, not everybody gets into rehab, not everybody gets a referral. We're looking at those that on paper would be appropriate, those when you actually see them would be appropriate, because there are some patients who have too many other comorbidities that it doesn't make it practical for them to participate, and then making sure that they get into a program that is close to them that they would be able to do. And then we look at the O to E for readmission, hospital readmissions on each of these and try to identify what are the things that we've missed. So it's a proactive effort to manage these patients as they transition. And after the fact, we look at where did we succeed and where did we fail. There's naturally going to be an up and down. You can't be perfect in everything, but that's our attempt to be a little bit more proactive.
And our winter meeting of December of 2017, we as a group identified readmissions as our #1 priority to focus on for the year of 2018. So what we looked at is through our shared database is who had the best or the lowest readmission rate in the Commonwealth among our participating programs. So we got the Centera group in Norfolk. We got, I think, UVA, and there was a third that I don't remember. Mike, I don't know if it was Korean or you all or who it was. And so in our first quarter meeting in 18, the groups presented what their algorithms were, what their approach was for readmissions, and then the resources were incredible. In my institution, we had 1 FTE that was tangentially associated with readmission. In Centera, they had 7. We saw, despite implementing and trying to be pretty aggressive, we didn't see much change. This year, we've had a huge shift of improvement to the point where we've been asked to present what we did as part of the system, and it makes me nervous, and I'll come back to that. But what we did was, it's multifaceted, and there's a 4-page document that outlines what we came up with in our consensus on the website as part of your educational aids that I would refer you to. But the preoperative in the clinics, in the pre-op visits, there's a whole big educational process regarding the hospital stay, the anticipated discharge dates of 3 to 5 days, then what the patients can anticipate. There's another class that's in the hospital that the patients can come to preoperatively, where a lot of the postoperative questions and challenges are reviewed, and opportunities and options are given for therapy and intervention and contact. Upon discharge, all the patients get a phone call from our discharge coordinator within 24 hours of discharge. They're seen in our office within 3 to 5 days after discharge, which was new. We used to see them within a week, which often, depending on if it was a weekend, maybe 10 days. This has made a huge difference. What I would counsel you, though, is that what are the 3 primary reasons for readmission? Atrial fib, pericardial effusion, and wound issues. Now, none of the things I've said have anything to do with how those things are treated. So I think that there's a artificial improvement with a little a of patient population. Have we cycled into sort of a sweet period? But secondly, we have seen how we changed addressing the patients upon readmission. They all go to an observation area, which is less than 36 hours. And pericardial effusions are handled with percutaneous drainage with pigtail catheters that don't require an open subxiphoid drainage, which is about a 3-day minimum time. That's made a huge difference. So they're drained, catheters out, patients are out. Pleural effusions, 4th common reason. They're drained in an emergency department setting or on the floor by one of our physician assistants, and then x-ray, they go out later that day or the next day. I'm not waving because I'm seasoned. I've got this fly that's finding me particularly attractive, which is where you are as you get older. So bear with me. So those are the primary things that really have made a huge difference. And again, some but not all are outlined in that resource. The one thing that is of interest to me is that as I stop and look at so many faces, we spent about 18 months on this issue, and we're still like, okay, what do we do about this issue? And I think that it underscores that in a quality improvement group like ours, it's pretty sexy to start off with new things, new topics, new therapeutic alternatives. But maintenance is an incredibly difficult and often unsuccessful path. And so we take it for granted that, what do you mean we got to talk about readmissions? We spend a year and a half of our life on readmissions. But as we turn over our staff and turn over within our different institutions with different nurses and database managers or surgeons or residents and PAs, this is all new. And so Linda reminds me on a routine basis, we're starting to see our transfusion rate go back up. We've got one of the lowest in the country, and about every 18 to 20 months, we see a spike because we've turned over. A third of our nurses are travelers. That's not any different from what you're faced with. So the maintenance of education, while often felt to be both boring and a drag, is critical, because if we're really to be sustaining our outcomes, we've got to find the ways to make it green, to make it real, to make it new, because it is new to so many people coming. So I think that's some of the things we could talk about, particularly with you all, with our quality group, is to what would be the optimum way, on what regularity, you can come up with the same questions I can, to make sure that the data on all the work that's been done can be revisited, and just, even if it's the high points, readdressed, so we can understand what some of these areas of what are our gaps and how we can sort of revisit this. Otherwise, like in atrial fib, we did great for about 3 years. The rate went up, transfusion went up, extubation went down. You can see where I'm headed with this. So I'm posing it to you as just sort of file it away, because we just, again, we get complacent.
If I can just add one or two other comments, that's a great point. There's a cycle that these seem to have where they go down and then go back up, and I think I agree with Alan. A lot of it is the education piece, and maybe each institution can kind of look at what is that cycle. Just like if you're taking a medication, you want to take the next medication at a time where the other one is wearing off. Clearly, the education piece needs to be a medicine, so to speak, that has to be given over and over, and what is that optimal time? So it might be interesting to look at. Yeah, so the other two quick points. We had someone from England talk about readmissions, must have been 2017. I can't remember who it was, but there was an analogy that I think is important, because we have to manage expectations. It's never going to be zero. You can try as hard as you can, and the analogy was you push a balloon and some other area pops up. So we just have to make sure that we're diligent and unrelenting in trying to look at this. The last thing I wanted to say from the standpoint of the heart failure readmissions is we've been working harder and harder, both with implantables to assess volume status, to keep people out of the hospital, as well as our heart failure clinics. We're also doing a research project looking at non-implantables but wearables, and how they might be used to help with volume management and keeping people out of the hospital. So from that perspective, we'll hopefully have more information.
In the 4 o'clock talk that Beth Strongmer to giving, part of one of my slides is talking about just retention of your goals. Old problems resurrect as new problems. And for instance, for us, we went from Cerner to Sorian to Epic last year. One of the things that, and this was my mistake, that we had been for 5 years, our antibiotic stewardship was 100%, and when we switched to Epic, you need to know your process. That's one of my slides, know your process. And we really didn't know our process very well when we switched to Epic, and yet we had stopped tracking at our quality meeting. I knew what it was behind closed doors, but at our meeting, it just disappeared off of one of our metrics boards. And the long and short of it is that in our Epic module, when patients come into the OR, there's a little reminder that pops up, and it says, give your antibiotic, before surgery. And so CRNA would push the button. What they didn't know is when they pushed the button, it actually documented the antibiotic given at that time. So if you came in the room at 5 to 7 and you cut skin at 8:01, that was a fallout. We didn't really find out until probably 30 days later. And I guess the moral of the story is you really can't say, well, we tracked 30-day readmissions for 18 months and we're good. If you're not continuously looking at all those metrics and your processes, the environment changes, epic for us. Your staff changes, we have tons of turnover. We're near Dahlgren, we're near Quantico. There's so many things that change in healthcare. It's such a dynamic process that if you're assuming that my performance is good because we put this into place and for 1 year we were doing well, you're probably going to see change. I can tell you for us, from a FIB standpoint, we track amiodarone compliance monthly for the last 7 years. And our AFib rate goes like this. And so there are some things I think that just are cyclical. You know, Dr. Na, who's our medical director, he'll say, gosh, I don't know what the hell we're doing. Why are we at 18%? And then the next year we're at 26%. We're doing nothing different. You know, the calendar turns over and the next year we're not doing as well. And we look and we see the compliance and it's hard to say, but we just don't take our eyes off of those metrics. You have to still, whether it's extubation or blood usage or whatever the case is.
Thank you, Mike. Does anyone else, or you have a response to that, Dr. Speir?
Not to that. How could I have responded to Mike? For those of you that are relatively new to this, keep in mind that the STS number, while it's not a fake, is probably significantly underestimates the readmission rate. So what we get tagged with is then CMS is reporting to the institution, and then we're putting out what our perceived readmission rate is. CMS is reporting all the readmissions for that patient regardless of the site. We're only tracking those that are readmitted to our site. So if you've got about a 6% or 7% readmission rate and you're patting yourself on the back, keep in mind that you may end up being about 50% accurate or 75% accurate. And it's not a bad thing, but just without calling the patients after 5 to 7 weeks or up to 2 months, you're not going to know. So just don't let that dissuade you from what you're doing, but it's also because we do what we can do.
Okay, excellent. So our next question has to do with shared information, but before we proceed, Dr. Speir referenced our website. There's some information as it relates to protocols we implemented together, so I wanted to show you where that was, even though the resolution is not very clear. So on our home screen, VCSQI.org, you click on members. It'll take you to an area usually asking you for your password, and the password is Richmond 2019 without spaces. And under shared resources, again, the resolution is not good. You click there and it will take you to all the protocols that we have implemented. Best practices, Best practices will take you to the protocols we developed as a group. Okay, so now back to the PowerPoint, and the question that was related to you, or that we wanted you to answer relates to communication, sending information back and forth. How do you go about, or what is the best practice as it relates to sending information from areas that doesn't have Epic? Here. You want me to start with that one? I can start. You want me to take you off the seat a little bit?
Please,
No?
go
Okay.
ahead. I'd love to hear what you have to say.
Well, one thing I can say, yesterday I had 2 site visits, and coordination of care is something that you have to work with your community. So as the quality improvement advisor for VCSQI, one of the things that I can do is, as I'm working with each of your programs independently, I can find out what your needs are as it relates to someone sending information to you. What demographic information, what information or a complete record which you need from those organizations that does not have Epic, and then post it on our website, and we'll work with other community centers that may be referring patients to you, just to find out what you would need and find out who you send that information back to. But overall, it's a process. You have to ingrain that process within your system. There are some programs I work with where there was a secretary who went through the list every day and made sure that that information was sent back to the referring provider. But this is a group effort. We all have to do that. If we all do it together, we will all get that information back. But it's just systems we have to put in place and just be conscious that we need to give that information back to those who's referring. Because the reality is, if you're not getting the complete record back, that's going to impact your referrals. Other physicians want to make sure that they know what's going on with their patients, therefore we'll send you more patients. So that's something I can work with you together on, just to find out what all you need. Okay, your turn.
Thank you. I think of all the challenges that we mutually have, I think that one may be the biggest reach. And I say that because on a routine basis, we fail at how this is done, at least in my world. It has to do with size of program. It has to do with the complexity and the relationships of the providers and the institution. And I think I would submit is unrelated to electronic health record. So despite all of the things that EHR was designed to do, which is to improve this, we're not able to get as much information in my world out of Epic as we are the mind-numbing time we spend putting it into it. There's about, I don't know how many cardiologists there are in aggregate, but it approaches 200 in the Northern Virginia area that are all separate and distinct from each other. And so when patients are referred for consideration for cardiac surgery, our office, it comes back to a human, has to contact those offices, look for CDs, look for CAS, look for echo results. And I would say we're good at getting the CAS, probably 80% when we're seeing the patients. Getting echo report or getting echo results, probably about 20% max, if that. So that would, the goal would, about of those 200 plus, probably less than 80 are employed. So their Epic is both as an outpatient and offices are there, but we're not on Epic. We will be in the coming year. So my point to this is the inconsistencies between and among all of the groups are huge, and there's no immediate solution without identifying them and how these resources are allocated to them. Because that's a pretty expensive FTE that's sitting there calling and coordinating, and that's not, since they're not generating revenue in your particular institution, that may be hard to come by. However, we see routinely patients that show up the day of surgery where new information has come in the interval that impacts us going ahead. So it's not like it's a huge issue and a huge problem, but we're seeking to continue to address it on all fronts, from the IT front, from the human side, and from us. The go-to, though, is picking the phone up and calling the cardiologist, or the cardiologist calling us. And yes, we may or may not be in an operating room or in with a patient, but I get the most information talking to a colleague, and it seems like in this day and age of texting, that's sort of dribbled off the cord. But that's, to me, the invaluable default, whether that's age-related or not, I don't know.
So he's passed the baton to me here. This is an interesting question that we've wrestled with like everyone else. And actually, we have 45 cardiologists and 20 APPs. And we go to 7 hospitals in Northern Virginia, 4 of which are Inova facilities. The overwhelming bulk of the surgery is done over at Allen's, the flagship at Fairfax. There are 2 issues that I see. One is the entry into the practice, and one is once they've had surgery, communicating back to the cardiologist. A lot of times the problem occurs because we have maybe 8 or 9 cathing cardiologists. If someone gets cathed and they're being sent for some surgical procedure, the hospital, the surgeon does not know who the primary cardiologist is. They know who the interventional cardiologist is. But I might see the patient back, because I'm a reformed interventionalist, I might see the patient back in 3 weeks and not have the surgical information because I never got the call and it didn't get into our health record because we are able to interface with Epic, but if it doesn't come to us and we don't know to request it, we don't get it. So we've actually had meetings where Alan and other people from his practice have come to our shareholder meeting to kind of figure out how to deal with this. And among the things that we try to do is I personally will call and I'll say, Alan, I've got a patient with a dilated ascending aorta that I want you to see. And so he's already clued in that I'm the one who's referring to him. So as Alan said, the direct communication there is no substitute for that. From a process standpoint, identifying who is the following cardiologist so that you know if additional information is needed before surgery or where the information needs to go after surgery becomes critically important. The good news is we're going on Epic too as an outpatient, so we'll be able to send each other notes quicker. But when you're not doing that, you really have to then have a process after someone has surgery for the surgical service to be able to identify the practice, and the practice has to then be able to get that information and put it in their records. So I think identifying what that process is, both on the intake and the post-surgical, becomes critically important. And we've worked very hard at the person-to-person communication and having everybody's cell number to say, I sent this person to Alan, but so-and-so is going to be operating, and they have my number to be able to let me know if there are questions or to let me know how things go. Like the AFib treatment with amiodarone, sometimes I get more calls and sometimes I get less calls. So it is an ongoing issue. Yeah.
So this was my question, and I will, I guess, extend on this question just a little bit. While I appreciate the direct contact and sort of thing, we need to understand that that's not something that's really feasible. I love calling and talking to people, but really there's not a lot of time. We have one data manager, actually 1.4 or 5 right now. Praise the Lord for that little bit of help. I don't think it's appropriate necessarily to look at it from the tail end. I think it needs to be addressed from the front end. I'm looking at adult cardiac, TVT, which includes TAVR and eventually going to be MitraClip, as well as LAAO. And they all have different follow-up criteria, and that is a source of contention for me. That is miserable. That follow-up needs to be earmarked on the front end. Is there a way? I was made aware of something called Epic Connect, and I don't know if any of my senior centers, any of my larger hospitals have something like that that can share about what their experiences are, but I can tell you the one cardiology group that we are dealing with, it's particularly painful to get information out of, and it's not fair for me to burden our CV surgical secretary to do all that. She's got too much to do now. So asking her to pick up the phone over each individual patient, that's just not going to happen, and I don't have time to do that either.
Yeah, so let me see if I am hearing you correctly. What you're describing is a situation where you're getting incomplete information on the intake to be able to manage some of these more complicated cases. Is it a protocol, a post-follow-up protocol also that you're?
It's specific to the NCDR.
Okay.
It's the TVT Watchman requirement for 30 days, 6 months, 1 year, 2 year for LAO. And same way with
And it's got a very tight parameter.
Okay,
So
one of
my
the
thought is, and I want to just throw it out there to those that are in positions of power to talk with legal bodies. Is there a way to create some sort of a consent that extends across the entire time of follow-up? That all this information, every time you get hospitalized, every time you come to see the cardiologist who may not be on Epic, regardless, that patient needs to be earmarked. My interventional cardiologists know, oh, I just did a TAVR on this patient and I'm going to take them back to cath at Spotsy Regional. I can't see that. It just was dumb luck that I stumbled across it. So we need to find a way to make that seamless. And then I have to be able to see what is happening on follow-up, and I can't. Is there a way to earmark these cases electronically on the front end? Once you go to surgery, there's a little star that goes on that cardiologist's patient's chart electronically that automatically will be a send to Mary Washington or to whatever hospital is doing the data entry. There's got to be a way to make this seamless and easier. And it's an electronic age. I love the person-to-person interaction, but really we don't have time for that. We need to make it more efficient.
That's a third issue that you were saying when someone is readmitted for another procedure, knowing whether or not they had something done before. So those are intake, routine follow-up, what are the post-follow-up procedures, and then how do you notify post, when they've been readmitted for something? Is that correct?
It is correct, but I think if we could earmark these charts, it could be a seamless process, and that would be good for everybody. It doesn't matter what hospital. If we know who is doing the data collection for these types of cases, like the Watchman, separate from TVT, these always will have to go to this record in the hospital and under outside records so that we can review them. There has to be a way to make that seamless and simple.
Are they all on the same EHR? Are they all Epic, or are they mixed systems? Okay.
I would assume that's the case for most of you, is that correct? Yeah, at your facilities, are your cardiologists all employed by the facility, or do they have private practice in their own EMR?
How many of you all experience this same type of scenario? Just give us a show of hand.
I think that one of the things that comes to mind to me, though, is who owns it. And you've heard from Robert, we've spent a lot of time and have tried to do a good job. It could be better in having direct surgeons sitting down with a cardiologist. And initially it started off with, you don't do this. Why don't we ever hear from you? It was fairly pointed. And then as the dialogue continued, it was a matter of understanding what our limitations are as well as their limitation. It then became a shared problem. But the key to it was there was also a shared commitment, is that we recognized what we needed to do jointly. And the cardiologists did their part in owning it rather than saying, you're not, just the finger pointing thing. And I'm struck as you're talking about knowing some of the principles there, that, we haven't routinely thought like this before. We didn't need to. The patients were not as complex. They were pretty straightforward. We saw each other more frequently, and now all that's different. But unless you start off, and whether it's routinely getting together to problem solve, I'm sure this is only one of many, but identifying the issues and coming up with as usual, all politics is local, and coming up with a way to solve that, you couldn't possibly get an answer in any kind of forum other than those cardiology groups and your surgeons to figure this out themselves. But it starts off with, do we have a problem? And recognizing that there's something that needs to be done differently. Because if not, it's going to be business as usual, and that everybody that comes into the practices will follow the trend, style, and practice that's existing. But they've spent, because of their size and the diversity of the different hospitals, they spend a lot of time talking about transfer of information.
The other thing that strikes me is two quick points, and I don't know if you guys are doing this or not, but Because of the greater complexity of the heart team type of cases, the TAVR, we end up having multidisciplinary decisions. And so we've got both sides working together. The other piece of it is that we have protocols for consistent follow-up. What Dr. A does on a TAVR and what Dr. B does on a TAVR, the follow-up is all the same. So, and we make sure that they go back to the appropriate person, again, identifying that. So communication, to reiterate, I think what Alan was saying is communication, setting up the protocols, and identifying the problems and coming up with a shared process to be able to fix the process is probably, it's not easy, but and it's an ongoing thing, but that's what we've done. And to answer your question about is there a simple way to do an EHR? Great question. I don't know. You may want to go back to your EHR or to the different EHRs in your community to see if there's a way you can flag those patients, but I don't know the answer to that.
Very much. So we're going to end on the last question as it relates to separating the two meetings. How does Dr. Speir and Dr. Shor makes the delineation of how we're going to proceed, when we have our meetings?
We're concerned about losing participation because of the program issues related to combined meetings. First of all, let me thank whoever put that in, because it's great when everything's going well, but these are the kind of questions that at its core people vote with their feet and they just don't show up. So I think it's great to get things out and understand what the needs are, your needs are, what our needs are, because they may be different. But first of all, you look around the room, if we split it up between surgery and cardiology, they'd be pretty small. And could you really have enough participation that makes any difference? But my editorial comment as a human, not as any kind of a chair or anything else, is that our future is the shared treatment of this patient population. I don't think any longer, although our history and training has been totally separate and distinct and often adversarial, that's not how we practice now. And that's not what our insurance demands are. That's not what our patient demands are. That's not what our hospital demands are. And so many of these programs are now no longer cardiology and surgery, but cardiovascular disease. You're looking at a shared governance. You're looking at shared models. You're looking at shared business models and reimbursement. Probably within the next 2 years, there's very real thought that Part A and Part B are going to go, or Part B is going to go away. That bundling is more and more the discussion. If it comes to fruition, I'm not that smart to fast forward. But then the institutions are going to be paid, and then the providers are going to separate it all out. The reason that's relevant, it's going to force more and more of such collaboration. That kind of collaboration starts in here, because one of the questions had to do with the patient that moves through cath and surgery, and then what about their renal insufficiency? That's our world now. The TVT, it's surgeons and cardiologists. That's our world. Anyway, just so as a thought, I don't think it's practical, nor is it optimum to do things as we've done. It's not going to get us where we need to go to. And so listening, if your mindset is about surgical complications and treatment of surgical-related issues, you're allowed to that. That's your deal. But at the same time, in cardiology, treatment about medicines for advanced heart failure may not be at all that interesting. But I would challenge you to say for every negative, there's so many more positives with the shared meetings. But again, Robert's going to be chair of this in January. That doesn't mean that it's now going to be cardiology. By no means is that the plan to shift this into a cardiology organization. But the patient has that disease, and there's many alternative ways of treating it, from internal medicine to surgery, to catheter-based intervention, to probably holistic medicine that we've never even touched on, but maybe it might be fun to have a session about that.
Again, I think it's a great question. I think because we are a continuum of care and we are constantly going back and forth between the surgical and the non-surgical perspectives in managing the patients, having us together is critically important. Having said that, there are some interests that people have and there are some differences. One of the things that we are looking forward to doing and have spoken with the folks at VHAC is to engage more with VHAC, which is, as you all know, Virginia Heart Attack Coalition, which is a multidisciplinary STEMI care network throughout the state, much the way the RACE program is in North Carolina. And that's a way of engaging and motivating people from the cardiology perspective to become more and more involved. The second piece of it that I would say is we had a fascinating discussion earlier at another meeting before this where we're looking at outpatient data and cost. And as we are constantly going back and forth between a surgical intervention and a non-surgical intervention or medical therapy, knowing what those costs and hospital readmissions and all that information is going to make us more one than separate us. And so I think it'll be very, very important moving forward for us to be looking at each piece of it, but as a continuum.
But before we leave this, I'd be interested in hearing from you. Is what we've said, is that you disagree? Do you think that's not at all what I'm interested in doing, and so thanks, but no thanks? I mean, you're the future of this organization, and I really mean that. The whole data and where this is headed. I mean, how do you feel about it?
Just raise your hands if you want to add something, respond to the question.
Does this resonate to you, or is it, what are your thoughts?
I would agree. I think, we have a cath patient who goes for surgery. After surgery, later goes back for another cath. So a lot of those things are intertwined. Our databases are becoming more and more interdependent, as you already talked about. And my role, for instance, covers both. So for all the reasons you mentioned and those, I agree. It's good to come together for the whole picture.
A lot of people not talking.
While I don't do cath PCI, I have other people from our hospital here that do. I think it's good to have it together. I've heard people grumble that they don't like it mixed. I'm actually an advocate for mixing just a little more for TVT and for TAVR, all that sort of thing. Watchman, those things would be good because I know there are other girls here, maybe some gentlemen as well, that are working within that. So, and knowing that I have somebody that's shoe into the ACC is good.
Any other comments?
I agree with Beth. I just wish that we had some breakout sessions. And so breaking out sessions to have kind of more specific on different data points and then coming together is what I would like to see.
It's a great idea.
Anyone else? My exercise.
Well, I agree that we need to work together on this, particularly the quality meeting. In the past, we've kind of focused on surgery and on the database and individual data elements. We may need to kind of revamp our quality meeting somewhat. Are we going to continue to do just database? Look at FAQs and questions people have, because the data elements are, while they're somewhat the same, they're also very different between the two databases. So we may need to do something with the quality meeting.
So maybe one of the questions I can ask you all is to let Sherry and Eddie know what your thoughts are. How do you think the quality meeting moving forward can be most effective in your daily life in trying to manage this? And then if we need to, we'll send out a survey monkey and try to implement little mini modules before we, breakout sessions before we get together as a group, or however the group just thinks that it would be best to do that.
Sounds good. Please expect a survey, and Mike has a comment.
I think that, consistent with what Dr. Speir said earlier, for the last 10, 15 years, we've worked on long vent, early extubation, AFib prophylaxis. We've worked on diabetes, antibiotic stewardship, all these things. And I think the next step is how do we work with cardiology in taking the next step in quality improvement. And maybe that's, we've struggled kind of with renal protection, renal failure, and maybe we work with cardiology on projects like that, which I think will maybe bring some more energy back to the group, because I feel like in the last 10, 15 years, probably about 2/3 of what we normally have attendance. And I think maybe we can pull some of those people back. And if we don't, then we leave them behind. But there are definitely some opportunities there for us. There are some cardiologists that are coming out now that have a different perspective on coronary revascularization versus intervention. It gives us a forum to be able to talk about those things and develop quality improvement initiatives that I think we didn't have the capability of doing before. And so I think there's a huge opportunity. We just have to make the best of it. We may have to redesign the meeting altogether. Maybe we do what Jessica said. We have breakout sessions for cardiology and cardiac surgery, and then we pull them together and see how we can share our data to drive those initiatives. But there's a lot of different discussions going on. One is the data quality meeting, which is data integrity. I think getting rid of that is not a great thing, because the one thing that VCSQI is known for is data integrity. Everybody is following those definitions. We get away from that, I think then we lose some of our credibility and some of the publications that we've had nationally. I think that's a detriment rather than,
I'm just concerned more if we split about losing participation, because we need to redouble our efforts to make this work, since we said we're a cardiac services quality group. And I can tell you administratively, very few hospitals can afford to send people to 2 separate meetings. So I think your participation would go down. That would be my concern administratively.
A session, breakout session in the same meeting, so instead of 2 hours,
That
the
same
first
meeting
hour
would be
is
fine.
split, and then the last second hour is everybody's
Yeah,
together.
but separate meetings is
Yeah,
not.
not separate meetings.
One of the things that Chris spoke about was the definition for acute kidney injury, the significant difference between cath PCI, which I don't do, and STS.
Want to have any closing remarks, Dr. Speir or Shor? If not, please give our distinguished leaders a round of applause.
Thank you.
Okay, all board members are excused to do your magic. And now I would like to introduce, Okay, without further ado, I would like to introduce to you Mr. Michael Brown from Mary Washington.
So yesterday, I'm just going to sit down if that's okay. Yesterday, let me jump back. A couple weeks ago, there was a data quality meeting, and I wasn't on the call. And if you're not at the dinner table, you're on the menu. So Beth put me on the menu, and I guess Beth volunteered me to talk about data analysis and quality improvement. So that's what I'm here for. Yesterday, Sherry and Ed came to Mary Washington. I think they were UVA in the morning. They came to Mary Washington in the afternoon and just kind of want to look at what we do in program development. And so I spent a lot of time just talking about how we measure analytics and drive our QI processes and all the things that we've been doing really since 2010, 2011. really haven't changed a lot in that regard. We've modified some things, we've added some things, but in general, we try to be pretty consistent with what we're doing, and I think the consistency has given us some consistent outcomes in general. Interestingly, when we were done talking, Eddie had like a little graph that he drew on a napkin piece of paper and showed it to me. He goes, "Hey, can you kind of focus on that?" And so I said, "Oh yeah, I'll make a little slide." And then later that evening, I had dinner and I was like, I think I want a picture of that. So I got into Microsoft Visio and I was making a flow chart and I thought, well, this is crap. I'm just going to take a picture because Eddie did such a great job of describing what I do, and I thought it was kind of cute. So this kind of summarizes in a good way what we do. There's just so many people involved. I think the one thing he kind of missed on is, he's got a few people listed at the bottom, but it's just a huge network of people. There's perfusion, anesthesia, there's dietary, there's pharmacy, there's care management, there's home health. A lot of people missing off of there. They're all part of what we do. I really be an idiot if I try to teach a group of quality people the basics of quality initiatives. I'm going to tell you that I've never taken a Six Sigma class. I've not went through the lean classes. I still work as a perfusionist at the hospital, and I'm the program manager, and I deal with structural heart and the valve clinic, and so I don't have a lot of extra time. I'd love to go to the courses, but I've read the books. Just like Donald Trump, I read all the books. But I think the thing that really helped me the most was I did a lot of research before I came here. Did a lot of research at the Cleveland Clinic, University of Pittsburgh, and that whole process of identifying a problem, coming up with a solution, analyzing data, changing your process, et cetera, and adapting. That really kind of helped me a lot more than anything. But the whole goal is you try to find out what your problem is. HRO tells us you should be focused on your failures and your weaknesses. Celebrate your good things, your achievements. But me, I'll be honest with you, I'm not a huge trophy guy. That's probably one of the things that's probably on my associate opinion survey as a leader. I'm not a big trophy guy. I've raced in Ironman races, and I've thrown the medal into the garbage and looked back at my wife's getting it out of the garbage can. You're going to want that later. No, I don't. I really want to, if I finish a race, I analyze what went wrong in the race and try to fix it. And that's what I do here with our team. It's not just me. It's a ton of people that are involved. The one thing I did when I first started working, and I think I've said that before at this meeting, is I continue to do perfusion. I worked as I had a PA type role. That's a long story, for about 7-8 years. So that gave me a lot of exposure to patient care. Worked as a perfusionist for 31 years. And I wanted to continue doing that. I think for a large part because it allowed me to understand all the processes. I pump cases. I'm part of the, when we transfer patients to the unit, I'm transferring the patient to the unit. I see the process that are going on. And you have to understand your process because that'll set you back just in QA because you've got to learn what it is that you're doing before you can fix it. That's a huge part of it, I think. You collect your data, you analyze it, you share it. The one thing I think there's people's definition of the 80-20 rule. I got the 90-10 rule. What I found out is 90% of the people are doing exactly what you want them to do. It's 10% of the people that are your rogue participants that say, I know better than your evidence-based medicine. And you can't be punitive with those people. You have to convince them, or you try to get rid of them. One way or the other. You just try to make it positive. And then you have to engage your team. You have to have champions. We've got a ton of champions. I have champions in anesthesia and the ICU and on the floor, and I'll talk about that. And then prioritize your goal. If you're not prioritizing it, then they're not going to. They're not going to think it's important to you. If you start an ERAS program and you don't have a lot of energy and you don't think it's important for patients, nobody else is. Your anesthesia team won't. Your nurses won't. Your therapists, nobody will. developing strategies that'll work in your system. One of the things that we talk about here is we talk about AFib prophylaxis and we talk about extubation and people. I've shared a lot of the protocols we have. I've asked others for protocols. But what works at Inova Fairfax probably doesn't work at UVA and it won't work at Mary Washington. And if you've taken one or all of our amiodarone protocols, you may find that maybe it doesn't work for you. You know, we kind of have a hybrid of Inova's and what was our original protocol, and it works for us. But you have to know your institution, what your resources are, so that you can make it work for you, get the results that you want. And then you need to communicate. In healthcare, I think we always make the assumption everybody knows what I'm thinking, and often the case that's not true. So you need to communicate not only your expectations, but you need to communicate as well as possible what the results are and stay on top of it. Again, celebrate the victories, but share the failures in the context of improvement and not in context of punitive measures. When people see that they're learning from it, and for lack of a better term, you're okay with them learning from it, if it means that they get better, you engage a lot of people, you make a lot of friends. And as things change, like we took Epic on, and Epic changed a lot for us. We had to revise some of our goals and our strategies so that it worked for us. It's that flexibility part that I'm not a super flexible person, and so it's made us all have to adjust and adapt. You guys have seen these. That's like the PDSA cycle and all this bugaboo stuff, so not gonna bore you. Where do we get our data? I mean, you guys, how many people here use ARMIS? And some of you don't. I have to tell you, I don't know what I'd do if it weren't for ARMIS. I can just write amazing reports. But there's other places you can get your data. You can get it from your EMR. That's a challenge. It can be done manually. It can be done through crystal reports. If you're like us, you probably are in a queue behind about 1,000 people who requested a crystal report. You can get it from your champions, the people you engage. And that's where you get your grassroots data that's really going to drive a lot of your processes, especially your patient satisfaction initiatives. And then formal, informal rounding. We have a bunch of different formal rounding processes, but it's as leaders, we're asked to informally round on a daily basis. Not asked, we're voluntold. But if you weren't doing that in the first place, then you probably weren't a great leader. And so you get a lot of information from just having those side conversations and talking to your team. And then whiteboards. I've been doing a whiteboard for 10 years, and I have to tell you, it's like the bane of my existence. I started it in 2010 when we really changed the way we were doing things with extubation and such. Somebody had made my director, Eileen, I think she's at the board meeting, she said, it'd be great to get a whiteboard. You just send it to me and send it to Dr. Na, send it to a few other people. Now there's like 30 people on this report. And everybody says, can you add this? Can you add that? Can I get fries with that? But it's that board is a way to communicate in real time, weekly, what our outcomes were. And it keeps people engaged. Not a lot of people respond to the email, but they use it. They use it to help with their reports, to track their reports. And I get individual emails back from leaders, physicians, and others about certain questions about patient care, certain outcomes. I'll explain to you what I mean by that in a minute. So ARMIS, I have to tell you, there's just the opportunities with ARMIS are endless. I don't like reading slides, but I just realized that's what I said. You get real-time analysis. Everybody does that. Hey, I want to know what I'm doing last month, and you run that report. I want to know how I did this month compared to last fall, or I want to compare, annual data. You can do anything you want. And in that regard, it's like getting your STS report on a monthly basis. You can look at your variances, find out where your weaknesses are, look at your trends and your predictors. I have probably about 50 different reports built into ARMIS for specific things. What are the predictors for AFib, and do I see changes in those comorbidities that gives me some insight as to why our AFib rate is up, or why our extubation is up, or why our blood conservation, blood transfusion is up. And so it's an amazing database. If you're not using it for that purpose, I highly recommend you find some people that can help you write the reports. I'd be happy to help you. I went down, I guess it was in 2010 or 11, and I met with, buddy, what's his name? Curtis. I met with Curtis. I spent a whole day with him, and he really showed me. I knew how to write some basic reports, but he really showed me how to just dig deep into the weeds, and it was probably the best investment in a day's time. Team collaboration. So our intensive care unit and our intermediate care step down, they have annual goals. In the ICU, one of the couple goals are cordis is out, the patient is dangled on the bedside, up in a chair, the Diprovan or Precedex is off within 45 minutes of arrival, things of those nature, ambulated by 7 a.m. We track those. I have a team, kind of a champion in the ICU, and she tracks all that. She sends me this report. I know you can't really see much off of it, unfortunately. But when there's a variance, she goes back and she sends a oops letter to the nurse and says, you didn't do your SAT, SBT based on the protocol. And then she sends them a copy of the protocol, and some of them probably get their nose up about it, but others, we got some new nurses in our ICU, they kind of appreciate it. If you get 3 1/4, it's going to go into your file. Now that's her doing, that wasn't my doing. She did that in conjunction with her manager. But at the same time, we don't have a lot of those. And it's helped determine who really wants to be part of our cardiac surgery nursing team and who doesn't. And when there are things to celebrate, she puts the best extubator, she puts the best ambulator, she acknowledges those people, and so people strive to be that person. Nobody really wants to get that oops letter, and some do. She sends herself an oops letter. She's a bedside nurse. She sent herself a letter. So, but it helps to engage the team. It helps to get the information out. It encourages new nurses, provides them the education so they can succeed. And as a team, nurses, they want to be acknowledged, and we want to acknowledge them because their role and their contribution is huge to our outcomes. And so this is an option or an opportunity to do that. Same way on our intermediate care. When you have an AFib protocol, and this would be very difficult to do at Inova and Centera, but when you have an AFib protocol, big question is, if your AFib rate goes up, are patients getting the amiodarone? So Barbie, she tracks it. Did they get their day of surgery amiodarone? Did they get their amiodarone post-op? She tracks it for compliance. So we know for the last however many years what our AFib compliance rate is with our amiodarone compliance is with AFib. Same way with ambulation, same way with getting a bath, getting a shower. Those are all issues. If you read your patient satisfaction surveys, patients complain that my corn was cold and I didn't get a shower for 7 years. You want to track that, and that's how you make the needle move, and that's how we do it. Same way with discharge education. We track that on a monthly basis. We've been doing it for 7, 8 years, at least. But it helps because if you don't do it, as I mentioned at the meeting before, old issues resurface and become new issues. And it'd be nice to think that you could take a protocol from here, go back to your hospital, and really work hard with your team for 6 months, put it into place, get excellent outcomes, and then kind of walk away from it and not water it, not fertilize it, not make adjustments, not trim the weeds up. You're just never going to get consistency. And again, if you want consistency, you have to be consistent with your message. Formal rounding, a couple years ago, maybe 4 or 5 years ago, there was an article that was published in JTS. It was a collaboration between the Society of Thoracic Surgeons, cardiovascular anesthesia, perfusion, CVOR, and it talked about transition to care. It said that 45% of all complications that occur in cardiac surgery occur in the OR because of a lack of communication, not understanding the expectation, what the goals were, and also not communicating what happened in the OR to the next level of care. So there's a break in the chain and the continuum of care. So we created, I thought these forms would be a little bit more visible, but I don't know how big the screen would be here. But these top two, come up here. These top two forms up here are forms that we use in the operating room for every case, regardless, TAVR, CABG, AVR, whatever it is. And it's a summary of the patient's history, summary of the medications they were on, the critical meds, all their labs, their imaging, all those things. And it goes through their organ systems. And I know, it's on the electronic medical record. Some of you may have this process built into your EMR. Epic has not been able to do that for us yet. But we've been doing this for about 4 years, maybe 4 years, I guess. And then on the back, it breaks down everything that happened during the case. And then we when a patient comes to the ICU and their monitors are hooked up, they're put on the vent, we have a timeout and we read this form. And then the intensivists are there, the nurse, the therapist, the advanced practice providers, everybody's there, and then a plan of care is discussed from that point forward. Really, and this was modeled after a study that was done at University of Pennsylvania called HATTRICK, Handoffs and Transitions in Critical Care. And it's won a bunch of awards. And so that's why we implemented that. I think Hopkins Safety Program has something very similar to it. It's a timeout. Just very similar to the timeout you have in the OR before you start your procedure. On the bottom left, that's the front and back. It's a form we use in the ICU for our rounding process. Same thing on the right for our intermediate care. And it has all our building quality improvement initiatives in it with the patient's 24-hour status. So if you're wondering about amiodarone compliance, if you're wondering about extubation compliance and following your protocols, it's all built into these sign-outs. And we have multidisciplinary rounds in the ICU at 8 in the morning, and we do it at 9 on the floor, and everybody's there, and it's a discussion, and we're consistently talking about those things. And it gives everybody on the team the ability to chime in about something that they're concerned about. Consistent communication. I think that's, if you're preaching the message consistently, then I think you're going to get at least 90% of your audience to pay attention, which is hopefully your goal is 100, but if you can get 90, I think your outcomes are going to be reasonable. What's it do? It changes the culture. Changing the culture at any institutions is a challenge. When you're trying to implement these quality improvement initiatives, probably your biggest barrier is the culture. But you're looking to get some consistency and some accountability. Looking at things on a real-time basis every week. This sheet comes out, and you can't see what's on there. I apologize. But basically, it's... Oh, well, that was dumb, Mike. No? There you go, Mike. way to go. Yeah, I'll do this. I don't know. I'll just use this. What do we got going on here? Help me here. It's like your screen. Sorry about that. So here's a good example. You know, I get an extubation outlier last month. We did like 20-some cases, 28 cases, and we had one outlier for extubation. It was 10 hours on a 50-year-old lady. That's not something we normally would see. So I sent an email out to the intensivist, to the ICU nurse champion, and to the respiratory champion and say, look, here's a patient medical record number, and can you guys help me? And I'd already reviewed the chart myself. It's not like I'm being lazy and say, do my work. And this is a response I get. I mean, I get this detailed response within a very short period of time from this gal who had actually, when she got the whiteboard, she started looking at it before I even asked her for it. And she dug right into it and found out. She took total ownership. You know, we have a lung recruitment protocol we use when patients come out that can't be extubated. And it was a new ICU therapist, and they weren't familiar with it. And she said, I'm going to go back and start doing education. The patient also was kind of tachypnic, and there may have been some pain control issues, and the nurse responded and said, yeah, you know, I also think that there may have been some pain control issues, and we'll go back to our team and educate. Of course, the intensivist got back and said, I think the intensivist did everything right. They'll never throw each other under the bus. But, you know, that really is, in a nutshell, the kind of the culture change you want people to buy in. And when you know, in the end, when you look at it, at the end of the month, you're taking all those things that happened during the month, from your rounding process, from your whiteboard, your communications from people giving you feedback. And every month we have our cardiac surgery quality meeting, and we discuss every patient's outcome. I showed Sherry and Ed what we do every month. We have the same PowerPoints. We put every patient up there. We discuss all their complications, their transfusions, their extubation time, mortalities. We also do the failure to rescue. Does anybody here remember failure to rescue that was presented here years ago? I've been doing that since that came out, and we discuss kind of a case study. And sometimes we're celebrating, you know, a success, and sometimes we're talking about, you know, a failure. And sometimes it leads to a new change in our processes. Last month we talked about a guy who got HIT, and it was a really, it was a very interesting case. It ended up being like a 30-minute discussion at the meeting, but we changed the way we deal with HIT now. And so a lot of good things come from it. But there's a lot of collaboration. Usually our meeting has somewhere between 25 and 45 people there, and from all walks of life. And everybody comes because they want to be, I think they want to be part of something that's successful. So you just have to be consistent with that data collection. And that's all I got to say. That's why I put that slide back there, because I thought it was pretty good.
Any questions for Mike?
Mike, do you actually have an AFib risk model, predictive model?
I have on an ARMIS. I have a report that I write, that I have created for it. I can share it with you. Yeah, be happy to do that. I have one for that, one for blood transfusion, one for renal failure. I've tried to come up with those for almost all the complications.
Cool.
Something smells good.
Sure does. Yeah.
Anybody else?
All right.
All right.
So for those of you who raised your hand relating to using ARMIS to extract data to promote change, can you raise your hand again? Okay, I'm going to go around the room and pick. Tell us how you use ARMIS to make changes.
I don't know, I just feel like I use it every day because you're looking at, you know, whatever. We have a whole prolonged vent because it's just like what you said, you know, in 2010, everybody was working on prolonged vent, and then basically all our nurses are new again, and it's like, okay, here we are back with a prolonged vent issue again, and just kind of restarting it. So, you know, every day I'm in ARMIS, you know, abstracting just those charts and getting the risk model and sending a report out every day, and it's exactly like what he said, like just having that in front of people. I mean, I think there's always opportunities to do more. I think your volume and what you do and it kind of can affect what you're doing, because I can't imagine any of our nurses volunteering to go and look at every single record for, 80 cases a month, but not that it's
But
impossible.
I do think that you could do a percentage of cases. I think you could say, we're going to review 20 charts or 15 charts. I mean, we don't obviously have the same volume. We average somewhere around, 25, 30 plus cases a month. And so it's doable, and I will say, if we were doing 100, 150 cases a month, you'd have to do a percentage, but surely you have somebody who could do a random, 15 to 20 cases a month.
Did
just
your
have to
nurses
find the champion.
volunteer for this?
Oh, they volunteer totally. Yeah, they're not voluntold. They actually are volunteers. Yeah. Yeah.
Okay, I'm gonna come pick with some more people. Didn't you raise your hand?
I did. I'm a new data manager, but for the most part, I use it for data entry. I use it to compile the reports, from our administrators, which is very helpful. And I use it pre-harvest reports to go look and see if there's any missing fields. So I'm learning more and more use for ARMIS in the reports. So.
Do any of you use ARMIS to create reports to drive your QI processes? Anybody? You guys do.
Yeah, raise your hands if
Up
you
back
create
here,
your own
you
reports.
guys do, right? Yeah.
There's just only 3?
I'm using it to drill down on specific data elements sometimes. Sometimes I'm looking to see what things might be missing for the entire year or for a quarter. And recently I got into STAR metrics. Since we had a little bit of help, I got curious and started fishing through STAR metrics, and turned out that was Christmas. That was Christmas. And if you're not using it, you need to be, because it will help you highlight where you might have something that was a typo. Somebody might have transposed a number or something, and you have something glaring red, and you'll know it before you harvest. So that's what I use it for. And the ability to run those data tables, that ability to Mike Brown, it's been hugely helpful for whatever question he asked me. If he asked me for something in particular, I can pull it for him. So.
Excellent. And now I forgot who else had their hands up. Who want to put their hands up again because they use ARMIS and create reports or use the data to make change? Sheila, I know you use ARMIS.
I'm using that every day. So I just would like to share something with you. First of all, thank you so much for the absolutely phenomenal comments and everything.
I expect a check.
Pardon me? I know that. That was my next point.
Just
That's
kidding.
Gonna be,
I'm not paid by ARMIS. I forgot to disclose that.
That's an expensive afternoon, yeah. So new stuff coming out pretty soon. And any one of you are using hybrid analytics? Okay.
I am.
Excellent. So we have some engineering time got back after did the hybrid outcomes override. So what we're gonna do is putting very useful and very easy tool on the top of hybrid analytics. So it's no longer you're gonna log into an empty page. You're gonna be able to create your favorite reports, label it, share it, and use it over and over again. Categorize them by procedure type, topics like, atrial fibrillation issues, prolonged ventilation study, everything. So that's coming. Don't ask me when. We just finally got some engineers back from those rewrites, so we're gonna focusing on that one. My presentation later today is going to show you some kind of stuff which I'm doing with the machine learning and artificial intelligence, predictions, very early stages. And the STAR metrics will get new functionalities as well in the next quarter, entering the decision tree
When are we going to get the bubble charts that you talked about the last meeting?
Which one?
Because, the analysis. They were bubble charts, weren't they?
Yeah, they were like those.
Bubbles.
Yeah, like decision trees.
The decision trees, yeah.
Yeah.
Now that's one that's coming in, and the control chart.
When do you think that'll be available?
I cannot tell you
I'm
that.
just
It's-
asking.
The web is very, very difficult, and we also started to write specification for the modern version of summary tables. It's not known publicly, only you guys know that, because the new version of summary tables on top of the hybrid system. So once we have that, I hope everybody can transfer to hybrid. But the hybrid analytics is a very important piece of this puzzle because we're enhancing that. I don't know if the new UI to creating new reports came out or not. There's plenty of new functionalities and selection capabilities, so you can do a lot of summary table type reports without really doing much as a summary table function. So the Outcomes 3 project, the one with Outcomes 3 which is using summary tables, will be eliminated as soon as we have a functionality similar. So that's the reason is that because we cannot maintain two set of applications. So it has to be in one platform. And
Is there a functional benefit to us?
hybrid,
Are they better reports?
there's going to be much better reports, and eventually going to be cardiology and cardiac surgery going to be in one platform on the patient level. I will talk to you about this later on. So it's a huge difference, and of course maintenance and functionality enhancement has to be done in one system. We cannot afford to have two systems running. So, any other questions? But thank you so much again for the very nice comments.
One question, when it was brought up, creating your own reports in ARMIS, there's a few of you that look like you didn't know that was possible. Can you, if there's anybody who's interested in learning how to create reports in ARMIS and don't know, can you raise your hands? No? Okay. So is there any training available to teach?
If you log into Zendesk, you can select the training sessions and sign up. There are videos available. I think there are interactive training sessions every 2 weeks, and you can sign up for that. Zendesk is linked. There is a link in the application to log into the Zendesk. Is anybody using Zendesk? Are you guys using Zendesk? Okay. Good. Excellent. Thank you.
Just a curiosity for myself, Jula. Explain the different programs. So we have ARMIS, we have hybrid, we have Zendesk. What are all three of them? I'm just,
Okay. So ARMIS is the company.
Yeah.
And hybrid is the new system, it's a platform. It's basically a generic application, like registry development tool. And we spent 6 years to develop this. And we're just learning that actually not many other systems, any out there similar to this. The Zendesk is a very modern customer support tool set where everything is linked to our ticketing system, which is called Jira, just to make things a little bit more simpler. Jira, we use Jira for internal projects and monitoring what's going on, who's responsible for what, what of reports or requests assigned to whom. Through Zendesk, the two is linked together, so we're trying to be as responsive as possible and also make sure that everybody who's involved and professional services help people, everybody sees everything. So it's providing us a complete transparency, both from a management perspective and individual people and you. So there's no longer an email which somebody forgot to answer. The system actually Zendesk prompting if somebody is not responding to the email to the customers relatively fast. If you have any kind of delay or something, please do not hesitate to push the help button again and go back to the same subject or something like that. But what was the other one? So hybrid, that's the new modern system which we developed, and people who are using that in other area, cardiology, childbirth, spine registry, everybody loves that. The reporting side is a little bit behind schedule, but I think it's going to be extremely useful very, very soon, and you will see a totally different kind of user interface where you can easily rerun, generate reports, save it with your colleagues, and they log in and see what you have done. So that's going to be very, very soon out. But the summary tables is with a little bit different functionalities, because hybrid analytics has a lot of functions which it would be very, very time consuming to repeat and redo at summary tables. But the summary table is what put ARMOS into the map, and I think everybody here who has been involved with us for many, many years would have a very difficult time to live with that. And even my job would be much, much more difficult, if even impossible, to do certain things, which you will see. So anyway, so these are the short answer to that question. Yes? I'm sorry? We're not going to, of course we're going to do. We're going to get rid of outcomes 3 as soon as the functionalities are in there in hybrid. Yes, yeah, even more useful. Yeah. No, we're not going to get get rid of outcomes 3 until until the functionality is available in hybrid. No, I can't guarantee that, because I cannot work without outcomes 3 summary tables, period. So it's not going to be ready, not going to be gone. We are writing the specification for that project, and after that it's going to be much easier. But I tell you that it's not going to be as fast as it was when we created that. The web is very, very different, very difficult, very time consuming. And so the hybrid system this is the 6th year doing this. Outcomes 3 was developed in 18 months, from nothing to full functionality. So that's the difference. 3.5 times more time and money and people. So, but that's where the world is going, is right? Yeah. Anything else?
So the versions won't really change until we do the whole upgrade.
What do you mean the version? There's no version changes in this year. We haven't received anything yet.
The version changes are going to go to the vendors in January. Okay.
That's what they say.
That's what they said on the call Tuesday. They were ready to go to the vendors in January, and that we would start the new version in July. There are 30% less data fields than there are currently. Whether that's useful, it might be something that we never use anyway, but it's going to be more user-friendly. They separated out some of the aortic and the aorta section. They put them all together. It's supposedly going to be better. But Juliet won't get that till January, and then they've got 6 months to trickle down.
No, we don't need 6 months, but conversion for individual hospitals will take longer, yeah. So I thank you then. But we have not seen the changes yet. I think Dorothy's passing put a huge break on that project, so unfortunately. Right, thank you again. Thank you.
Yeah, he wants to hurry up and sit down, I noticed. Okay, dinner is almost ready, but before, we're just waiting a couple of more minutes, so let's dive in a couple of FAQs. One of our favorite things. So let's say, Judy, I think this is one that you gave us. Yeah, so here's a scenario. The patient has the following: ascending aortic repair in 2008, hemiarch in 2010 at TEVAR, or is it TEVAR? How do you pronounce TEVAR? Okay, to descending in 2015. He is now coming in for open heart I still haven't learned these difficult words yet.
I sent this question because I wasn't sure about like what incidence of surgery it was, because he'd already been, and actually, he actually had more than this. I just made it simpler for the question. But, so the ascending was in 1 year, and then a hemiarch, he had gone back and had a TVAR, and now we're going to do a thoracoabdominal. And the question is a thoracoabdominal aneurysm repair, what incidence is it? And the answer is going to be, it is an NA. It is not considered a cardiovascular surgery, so it's the last choice in that, which I have to be honest with y'all, I have not been doing that. I don't think it's a big deal because it's not in a risk model, so I don't think it's that big a deal. And I do think it brings us up to the other question of like what actually is a cardiovascular procedure. If you've had a TAVR in the past and you come back for a CABG, that's your first surgery ever. But if you've had a TAVR in the past and you come back for an AVR, then they say that that's your re-op, your first re-op. And I guess she had actually said pericardial space in this. And before, when Dorothy was here with us, she said into the pericardium, because we had that question about the epicardial lead placement that actually counted as a cardiovascular procedure. I mean, so it all blows my mind. But just so you know, if you have a thoracoabdominal or a descending, they're considered NA, not a cardiovascular procedure, which probably everybody else knew that, but I haven't been doing it, but I will now.
Thank you, Judy. Thoracoabdominal. Okay. All right, another FAQ we have. How has surgery programs communicated how they are handling the heparin shortage in their cardiac surgery populations? So is there anyone who want to tell us what they do in their program, how they handle the heparin shortage?
I talked to our pharmacist this morning knowing this question was coming, and she said we're not having a problem.
Okay. Anyone having any problems with heparin? Yeah. That sounds good, but no one experiencing, according to your pharmacist. Okay, got it. Another question we can ask that was thrown out? Oh, well, here it is. No, that's the other one. Question 2, how does your program document ascending aortic procedures? Does anyone want to share how your program document this? These are a few questions that were submitted for, to our quality team, just to find out what other programs are doing.
Like in ours? Like a question behind it.
You put it in a database.
Yeah. Maybe in a chart? That's the only thing you put it in a database in ARMAS. Yeah, we'll skip this one. Whoever submitted this.
Maybe it's a question of it's like the root goes in the valve section, do you still fill out the aortic section? But
You're supposed to be putting it in both if it's a root, but they did say on the regional call the other day that the aorta and the aortic section will be together, and there will also be an aortic section. You will only put it in one. If they have a root, you'll put it in this one. If it's just simply something else with the aortic valve, you put it in the aortic section, but it'll only be one section in the new version.
I think I know what this might be about. I'm not sure this is what this is about, but it says open arch procedure, because you do say, yes, they had a planned aortic procedure. And you go in so it takes you over, you go to that thing, and then you get down, you give all the descriptions, and you get to the procedure place, and then it says open arch procedure. But when you look at that's the parent to all these things that come underneath, and the first one says ascending. And so what they did, if you go and look at the training manual, they crossed out arch and said open surgery procedure. So I'm sure they'll fix that in the next shedizzle when it comes out, right? And then you still click ascending. That might be what that's about. And I did change to that once. I don't know, somebody told me to do it. Dorothy or somebody told me to do it. Or Linda, no.
Thank you very much. All right, just a few more minutes and we'll have dinner. Okay, here's one. What is the definition of persistent AFib? This is yours, too? Okay. We love you.
I have to tell you, I ask a lot of questions, but this came from the FAQ in August about if you've been in AFib for less than 7 days, but you required something to get you out of it, you were persistent, and this is very, very important because it affects the risk model. And I mean, in my mind, paroxysmal means you just go in and out of it. I don't care what it took to get you out of it, but evidently, and like even my cardiologists, like when you look in your record, all my cardiologists say paroxysmal. I mean, like that's their profession, and they're saying paroxysmal, but the definition that's written down there in the training manual says if you've been in AFib for less than 7 days, or greater than 7 days, or longer than that, and it took something, cardioversion, meds, whatever, I guess that's the only two things you could have really, but to get out of it, then it's considered persistent.
Judy, did we say that even if it was that one time?
Yes. So I don't know if you have a copy of that, because that was the question on the call, Maggie, that if somebody had, Linda had a person who had AFib 10 years ago and got cardioverted, and never has had an episode of AFib since then. That's still persistent AFib. They wrote me that, and we got a copy of that. I don't know if you have that. Okay, yeah. And then the other question, there was another question that I was supposed to ask, and I did ask it, but I forgot what it was. That's okay. It's the same thing. No matter how, there was no age time. This does not expire. If you ever had it, you get to have it.
All the questions you sent me, Judy, are sent question sheet. Anything we discussed, in emails and stuff. I've tried to put on the
Is
questions.
it the STS thing that he provided?
Yes, questions.
Okay. All right, so let's wrap up with the last question, and then dinner may be ready. So this is something that most programs have actually spoke about. Mike spoke about this at the last meeting as it relates to Gatorade. So there's a concern for diabetic patients. Is this really the right thing to do, or does the evidence, because the evidence has been weak. What is your experience or recommendations? Because I know, Mike, you do Shor instead of Gatorade.
Appreciate it. We give a half a bottle to our diabetics.
Half a bottle of Shor.
Mike, have you looked at your peak glucose intra-op and your...
It was high. That's why we switched to half a bottle.
Okay.
But, in talking to the Ensure rep, the Abbott rep, I mean, you're going to expect that. It's how long it takes for it to go down. For us, that was the issue. When they came in, when they came in the same day, they got a blood sugar, it was up, and then when they went to the OR, it was still up, and then we got one before we went on pump, and it was still up. And so it really should go up and then start coming back down. It wasn't, so we went to a half a bottle, and that's kind of rectified the issue.
We're using glucometer in the OR, and it's still staying up.
You're using Gatorade, right?
Gatorade.
Yeah, that might be the reason. I don't know.
Okay. So, Mike, just to put you on the spot again, since you've been using Ensure, what data, what research, do you see a clear delineation or difference as it relates to the advantages of Gatorade Ensure versus Gatorade?
We never use Gatorade.
Okay, you never use, okay. Okay. Yeah. Okay, I'm sorry, we're still waiting a little bit for meals. So let's go on to another question. Which program are doing cardiac ERAS? Could run a report, well, that's something different. Could run a report to the highest glucose intra-op and the VCSQI field for the BPG in admission and to the ICU for centers who are doing Gatorade. So that's a report we probably can create, but which programs, cardiac programs, are using cardiac ERAS? Just to show your hands. Do we have any cardiac ERAS users here? Okay, Judy. Was this your question? Want to dive in a little bit deeper?
No, I do not. I do not. Mike answered all my questions.
Sounds good. We just love you, Judy. You know. Do we have any more questions? Other programs using nurse administrative anesthesia to reduce the lengths of care for say. How are other programs using, did we talk about this already on the call? How are other programs using nurse administered anesthesia and reduction of length of stay for TAVR population? So what are you doing? Yeah, that's what I'm assuming. I'm not quite sure who submitted this question. Anyone knows? Let's just assume it's for conscious sedation. Let's assume both routes and then answer the question for whomever.
Like she was saying, is it just a nurse?
Yeah.
Not, I should say, not just a nurse. Was it a nurse anesthetist? Are they saying that they're not using anesthesia personnel during the TAVR phase?
They're doing MAC instead of general on that, that's what they're saying. Monitoring anesthesia because we're not getting anything with now and then.
Okay, so I think that is the last of our questions for the FAQs. But do you guys have any questions about anything that is going on in VCSQI, even though we're going to give you an update later? Or you have a question for Judy or any other program? Does everyone know everyone? It's a couple of new faces here. You want to introduce yourself?
Sure. I'm Jeremy Fletcher. I'm the Senior Director for the Cardiovascular Institute at Brook.
Glad to have you.
Thank you.
He's from where?
Brilliant.
I haven't seen your face before. Okay, because I'm just, I have Oldheimers. All right. Peggy, everyone knows you? Yeah, so this is the fabulous Peggy. We're going to talk to her a little bit more later, but this is Peggy from ACE.
Peggy McElligan with ACE, the Accreditation for Cardiovascular Excellence.
Woohoo!
And this is Zach, he also works with us.
All right, Zach, nice to meet you. Yeah, okay, I remember.